Yes. Is there a risk if you don't perform hand hygiene for the appropriate amount of time? 100%. There's a risk there. But we mitigate that risk often, hopefully, with putting on sterile gloves and sometimes 2 sets of sterile gloves, right? So we mitigate things and we try to minimize the risk.
Clock in, scrub up, and join us behind the red line, where infection stops and information starts. You're listening to a special combined season of First Case and Transmission Control podcasts, bringing perioperative practice and infection prevention together to tackle one of healthcare's most persistent challenges, surgical site infections. Each episode will connect you with frontline staff, perioperative leaders, infection preventionists, and healthcare innovators sharing real-world strategies, stories, and solutions that are changing the way patients receive surgical care. From the back table to the boardroom, from wheels in to wheels out, and from surveillance data to safer practice, we're breaking down silos and strengthening the systems that protect surgical patients. Welcome to Silo-Free Surgery.
Hello and welcome back to part 2 of a special season with combined transmission control and first case podcast. We're joined by Lindsey, Joyce, and Jeremy Gibson-Roark for part 2 of a conversation about investigating surgical site infections, but maybe not from the traditional standpoint that we come at these. Think more collaborative, more silo breaking, more involved in your OR and in IP. So Lindsey, Jeremy, welcome back.
Thank you.
Good to be here.
And for those of you listening, it was like a 5-minute break between part 1 and part 2. So you just have to use your imagination about all the good conversations we had while we were breaking for 5 minutes. So I want to kick this conversation back off with a document that, and Lindsey, you'll have to let us know how much this gets shared with the OR, because it's one of those key documents for infection preventionists, and that's your annual IPC plan and risk assessment. And Jeremy, I want to ask you how that gets developed, how surgical site risks are pulled into that document, and how much that's shared with the OR. So Lindsey, we'll kick it to you first.
Well, can I be completely honest with you two?
Yes.
And tell you that I have never heard of IPC until now, unless it's called something different where I've worked. So you guys are going to have to teach me about it.
This is a perfect place to start, because this risk assessment, this annual risk assessment, we think about it so much from an IP perspective, and then I feel like we don't share it enough, or we don't even educate about it. So, Jeremy, what's your approach on this?
Okay, so I have a whole different concept. Number one, the use of the word annual risk assessment is something that I think we need to change the mentality on. Your infection prevention control risk assessment is what you do to move from a reactive organization to a proactive organization. So rather than reacting to a surgical site infection that has happened, your risk assessment allows you, or should allow you, to identify your risks so that you can mitigate those risks before they happen and before you have a negative patient outcome. And if we're only doing it once a year, think about how many things change throughout the year. And let's just talk about surgery. The rest of the hog, think about how many things can change in surgical services throughout the year. You could have a new physician. You could have a new service line. Lindsey, you mentioned, I think earlier, y'all were doing CVO or thoracic robotics, right?
Yep, we're starting that soon.
So that has its risks. And if we're not updating our risk assessment, I steal this from one of my colleagues, Leslie Lloyd. She's my work wife. But it should be a living document. It's something that is ever changing. We're looking at it on a quarterly basis, or however often, more often if you need to. But when conditions change, we should be updating our risk assessment.
Mm-hmm.
If you are seeing an increase in if you are seeing an increase in surgical site infections, we should be updating our risk assessment to capture that, right? And then our plan, our infection control plan, is developed by that. And The other big misnomer, and Lindsey just pointed it out, is the infection control risk assessment is the sole responsibility of the infection preventionist. Well, technically, yes, they hold the document. But if in a successful organization, that document is passed to, and again, we're kind of focusing on surgery here, it's passed to the surgical services director or manager or whoever's assigned, and they say, okay, what are your risks do you feel like your biggest risks in your department are from an infection control standpoint? And they, hopefully will list them out. And then that becomes a participatory document so that somebody's not telling me as the OR director that hand hygiene is our biggest concern. When I know that our biggest concern is that we're adding robotic thoracic surgery into our program. That's my biggest concern, because you've got draping and complexities that you've got to teach and educate staff on, and so that infection control risk assessment is something that more often than not is used as a checkbox item. I do it once a year. It's done. I can check that box off and move on.
Then it sits on your desktop for the next 12 months until you open it up next year. And Jeremy, in your experience rounding and auditing different sites, your work as a surveyor, what are some maybe red flags? One of them obviously being when it's only updated once a year or even less than that, right?
Yeah, we only require them to be updated annually. So by using it as a living document, you're really putting that into best practice. So don't get me wrong. If you're just doing it once a year, you're meeting the expectation of the standard, and that's all you're required to do. I'm telling you that hopefully you're using it as a benefit, not as a checkbox exercise. The big red flags is when you open it and you look at it, and typically your accrediting organization has access to 3 years worth of data. And you're looking through that infection control risk assessment, and it's the same thing every single year.
Yeah, just copy paste new dates.
It's copied and pasted in, and our risks never change. Or, you're identifying hand hygiene. I just pick on hand hygiene a little bit. You're identifying hand hygiene as a high risk, and then I'm going and pulling your compliance data where you've done your compliance audits for hand hygiene, and everybody's somehow in the 90 to 100% range. Well, that's not it. If your audits of your hand hygiene are accurate, then that's not a risk, because you're pretty effective in it. Now, I might question your hand hygiene audit data a little bit, but
100%, 6 months in a row.
Yeah, but that's just a kind of an example of things that are red flags where your risk assessment doesn't match what we're seeing in the environment. So if I walk down into sterile processing, and on the clean side, it's the repository for all of the old equipment, and there's an inch layer of dust on things in the clean side of sterile processing, and then I pull your infection control risk assessment and don't see anything about sterile, it's going to throw up some red flags.
That's a huge one. Mm-hmm. The equipment piece, the environmental cleanliness piece. Are you seeing more, or do you expect to see immediate use steam sterilization also identified as a component in that risk assessment for SSI?
If an organization is utilizing it, yes. Mm-hmm. Some organizations have eliminated it from their workflows. And so in those organizations, if it was on there, I would question why you're not doing it. You hadn't done it in 2 years. Why is this still on your infection control risk assessment? If it's something that you still utilize for urgent or emergent cases, level 1 trauma centers, it does have its purpose. So yeah, if it's still being utilized, then certainly it probably should appear on that risk assessment.
So, Jeremy, I have a question, and I am not in leadership or anything, but I know we have a lot of surgical leaders that do listen to both sides. So what is something that a surgical service leader can then they can pass it on to their frontline staff. What are some things to help them understand why this matters? Because like I said, I just admitted to you that I've been doing this for 18 years and I have never heard of this type of documentation. So what would you share with leaders that they could share with their staff, not only about what this document is, but how it can affect their day-to-day work?
Yeah, well, number one, we got to educate what we're using it for, right? So I go back to what we talked about in our last episode. The best information you can get is from your frontline staff, and involving them in the process of identifying risks into what do they see, or what the best question to ask in a staff meeting is, hey, guys, what keeps you up at night from an infection control standpoint? And this can be just between your surgical services questions and the frontline staff. What are we doing that keeps you guys up at night? Or, you go home and scratch in the back of your head. I don't feel like that was, what are those things? And then, kind of taking that data and then from the frontline staff and compiling it at the manager or director level, and then passing that information on to the infection preventionists to help solve. Because they're going to have resources that, hey, they may be able to get things that might support some process improvements in surgical services that improve patient outcomes. So they have a budget on their own. So, it's multifaceted, the benefits, but I think you've got to start by educating and saying, that's an infection preventionist getting in front of frontline staff and explaining, this is what we do, this is why we do it, and I can't do my job without your help. So if I'm an infection preventionist, I'm going to those staff meetings and I'm saying, hey, you know what? We can't be everywhere all the time. You guys see everything every day. Our job is to identify risk and to help you guys come up with either, administrative controls or engineering controls to help reduce that risk. But I can't help you do that if I don't know the risk is there. Mm-hmm. So then from a leadership standpoint, it's all about communication. And, again, kind of back to our conversation on the previous episode, it's not having that adversarial relationship. It's not going and I don't know, preaching, for lack of a better term. It's being receptive to information as a leader and not taking offense to it. Yeah.
And for our listeners, you can see both mine and Lindsey's eyes light up at that question of going to your OR staff and asking, what keeps you up at night from an infection prevention standpoint? Because I'm sure that they would have insights and information that you might not get any other way other than asking the people that are on the front line, in the nitty gritty doing the work. So, Lindsey, I'll ask you this one first, and then Jeremy, what concerns keep you up at night for IP in the OR?
Wow. Like you said, that was just a thought-provoking, make you stop and think question. I guess my concern that you think about, like, you don't think about maybe like dusting the cabinets necessarily in the, ORs or whatnot, or in a terminal clean, or what exactly does a terminal clean entail? And is it really being done? I know we've all probably shown up to the OR the next day and you find blood on the wall or you find blood on the floor. And it's like, well, then was this room really terminally cleaned? Is it ready to go? Dust in, like you said, in areas maybe that just kind of get overlooked. You see the surface right there in front of you, but are you looking at, say, behind your computer? Are you looking behind screens? Are you looking, underneath like an anesthesia cart? Is stuff really getting moved? Those would probably be some things that I'm thinking, like, look at those little lesser known, overlooked easy spots in an OR.
Those are great examples. Jeremy, what about you? What type of things are we missing or that keep you up at night?
I think the thing that keeps me up at night is ensuring staff are following manufacturer's instructions for use. And that goes from cleaning agents and dilutions all the way to sterilization of instrumentation. I think it's a big challenge in healthcare, one that I'm glad that I think is starting to get the attention that it deserves.
Mm-hmm.
There's just so much variation. I mean, from a environmental services standpoint, I mean, the things that we require of our entry-level positions in healthcare that are impactful to infection control, and oftentimes we're not giving them the resources to actually complete the job that we're asking them to complete. So think of some of the most impactful things to infection control: environmental cleaning, sterile processing. Most of those in most of our facilities, not all, but in most of our facilities, are entry-level positions. We're asking them to dilute chemicals that an improper dilution could harm them if they over dilute, or harm a patient if they under dilute.
Yes.
And how much education and competency and training are we doing? It's just, there's just so much with manufacturers' instructions for use and how they touch everything we do from a patient safety standpoint. That's the one that I wish that we could get our head around and understand the impact, the potential impact that it has to our infection prevention and control programs. And I think I get brushed off a little bit sometimes when I'm asking about them, and they're like, well, yeah, it's right there on the bottle. Okay, well, what does it say? And if you pick up the bottle and read it, something that you've been using for 12 months, that could
That's a really good example of one. And I know in rounding in the OR, I asked a staff member a question about a piece of equipment that was in the room. It gets cleaned between cases, hopefully, ideally, right? And so you ask the staff member, where's your IFU for cleaning this? It was a Neptune or something like that, a piece of anesthesia equipment. Where's your IFU for cleaning this? And the response was, well, that's SPD. They handle all the IFUs. And that's a huge culture shift that we have to change. There's IFUs for patient care equipment. There's IFUs for low and intermediate level disinfection for things. And I don't know how that culture changes to where we recognize that there's an IFU. Some of it is updates on the IFU piece and making sure that they're practical, useful, that they're accurate to a clinical setting, and not just, they can't only work in a lab.
Yeah, we've got to work on, this is a top-down, sideways, all-around problem from manufacturers that, write it where you have to have, a microscope to read it.
Yeah.
Us actually putting it into practice in our facilities. So it really is, it's an all-around issue that hopefully, as we advance with technology, we'll be able to better achieve in the future as we move away. And we see electronic versions now where we're not having to keep giant binders full of paper IFUs, but even those are still cumbersome sometimes to navigate. So hopefully this is a problem I think AI can really be assistive with, because you can ask ChatGPT how to, if you're not sure, what are the steps to clean this piece of equipment, and put the model number in. So I don't know, maybe that's wishful thinking, but it is a big challenge, and cleaning of equipment, that's a whole another issue between ORs and make sure it's cleaned. And this is where your infection preventionist can help you out, because this is where they can stand by and watch. And I can tell you, I'll admit my own bad practice. I can tell you, I can't tell you how many times I went into an OR next door and grabbed a piece of equipment that there was patient on the table in there, and I didn't wipe it down or clean it before I took it in that wasn't it. I was never trained that way. It was like, you need it, you go get it. And so it's really kind of changing that thought process, and you got to stop and think about, okay, did I just go into a room with a patient that had MRSA and bring this piece of equipment into my total joint room?
Yeah.
I was just thinking about our practices a little bit and things that we do.
That goes back to a conversation we got into a little bit on the last episode, is really attribution. and how much is causal, how much is a correlation. One of the, I would say, culture changes that can lead to a shift in breaking down silos is not, and I want to say this carefully, but not crying wolf that every mistake or error or problem in the OR is going to result in the harm of a patient, a surgical site infection, the death of a patient. And I'll tattle on the IP side that sometimes that's the thread we pull really hard is, oh man, you washed your hands for, 29 seconds instead of, and you're going to kill somebody. And we all want to protect patients, but I don't know that and it's not every IP and it's not every facility, but I don't know that approach is exceptionally helpful when we kind of paint the picture that every mistake or every gap is going to result in a surgical site infection.
Yeah, I mean, I agree with you 100%. I think that it's all risk-based. So, it comes back to, I feel like a broken record sometimes. It's just having that risk-based thinking. Yes. Is there a risk if you don't perform hand hygiene for the appropriate amount of time? 100%. There's a risk there. But we mitigate that risk often, hopefully, with putting on sterile gloves and sometimes 2 sets of sterile gloves, right? So we mitigate things and we try to minimize the risk. But you're right. Nobody should go in, and I hope nobody takes this conversation that we're having, that some of these issues and challenges that we're discussing are going, if they're happening in your OR and you don't not having surgical site infections. I mean, it's just looking at the risk, and it comes back to, I think in our previous episode, how can we eliminate ourselves if we do have a negative outcome, how can we eliminate ourselves as the cause?
Yeah, that's a really great point. And Lindsey, I'm curious, have you seen that with IP, with the interaction between the OR and IP where everything is a fire, so nothing gets treated like a fire? Have you seen that play out?
Absolutely. Yeah. If you get that fear put into you, like you subconsciously, I'm again, speak for myself. You subconsciously stop for just a moment thinking about that patient and thinking about, oh my gosh, somebody is watching me right now and they saw me drop my pen and I picked it up and I used it to write something and I didn't wipe it down because it landed on the floor. Like you just kind of have, and then over time you kind of get back into that mindset. But absolutely, when you have like big brother like watching you through the door, or you just see somebody staring at you, I think we kind of all get that regardless of what, if somebody's watching you. I feel like that's the time you're going to mess up more than if you have somebody not watching you.
Yeah.
It's even worse than when they come into the room and, they're sitting there watching you. And
so Lindsey, let me ask you a question. So let's take the scenario that we kind of talked about last time. And that was, let's say you have someone that is solely dedicated, an infection preventionist that is solely dedicated. How big of a hospital do you work at? I'm assuming you have more than one infection preventionist there.
I believe so. Yeah. We're a 24 bed, about 500 bed facility.
Okay, so you have more than one infection preventionist. So if you had an individual that was solely dedicated to the OR that you saw on a monthly basis, I mean, do you think over time it would relax that kind of feeling of I'm being watched? Or
I would hope so, because you would get to know that person both in what they're doing professionally, but maybe also, you talk to them in the hall, or how was your weekend, or how's your family? You kind of start to build that rapport, and then you start to build that trust. The OR is all about building trust. If if you're brand new, whether you've been a nurse for 20 years and you're coming in for a change, or if you're a new grad, like, we will be very skeptical of anybody new in the OR regardless, until you kind of, for lack of a better word, prove yourself that I can trust you to be in this room and not, contaminate a field or something. But if you have that same person coming in and, you get to know that rapport, then it's a little less likely that, they're going to sit here and nitpick and, be mean or whatever. That's why I love that idea of having like an infant, and I would love to hear in comments from our listeners if anyone's OR does have an OR specific IP person that comes down and works with them. But I think if you'd have that person, I would feel probably a little less intimidated or feel like I'm being watched versus somebody who comes down that I've never even seen or met in my life.
Yeah, we're very skeptical of unknown faces in the OR.
Very.
Why are
For good
you
reason
here?
too.
Why are you breathing air into my space, right? Yeah. So
if I haven't seen you around the OR, I will stop and question people. Like,
and
are you sure you're in the right place?
Yeah, and it's all about the approach, and that's where I just stress to the infection preventionists. You know, if you want to go and observe a case and you've not been down there before, you know, go before and introduce yourself to the staff, interact with them, see the whole process, see what all they have to do. Don't just go in when, you know, all the instruments are laid out and the patient's rolling into the room. Go in beforehand and see that these people are working their butts off. And there's a lot of opportunity from an infection prevention standpoint that happens before the patient enters the room. And, you know, build that rapport. And you know, that first time, if it's your first time going down there, just ask questions. I almost wouldn't even write a report unless I just saw something just horribly egregious, you know?
Yeah, I like that. Like, nobody sees that it takes me I do cardiac. Nobody sees that it takes me 45 minutes to set up 2 tables and 4 Mayo stands before that patient comes back for your on-time start. Or, you know, if you're in neuro or doing totals, nobody sees that you're in there for that long with, you know, 20 trays of instruments that you're trying to check and make sure that there's no holes and there's indicators and everything you need is in there and it's clean before a patient comes back. I feel like a lot of times nobody sees that aspect. They're just coming in and they're starting to prep and, you know, their glove accidentally touched this, or, you know, they're prepping and the phone's ringing, or, you know, the rep wants you to do this. They sometimes don't see that we're being pulled in like 4 different directions and trying to prioritize what is most important for patient safety. Obviously it's always number one, but what of these 4 things is the number one most prioritized for my patients? So I think I like the idea of, you know, coming in even from the pre-op aspect. Just start from the pre-op aspect, see how they're prepped there, come to the OR and go to the PACU, just as a whole dynamic from start to beginning or from start to finish.
And for sites that don't have the staff to have a dedicated IP over working with the ORs, we tend to say over, but it's, you know, working with the OR. I think even dedicated days where I'm not personally a huge fan of surprise visits. The assumption that they'll just be on their best behavior if I'm there. It's like, buddy, I want to see them on their best behavior. And believe me, some people's best behavior you will still see plenty of opportunities for improvement. Just because somebody knows you're in the room, they're going to be more relaxed. So if you don't have a dedicated personnel, would it work to have, hey, the first Tuesday of the month, I'm going to be in the OR in Dr. Smith's case, and we're going to watch her do a cabbage, you know? Does that improve the dynamic? Does that improve the strength of stop the line culture if we adapt it that way?
100%.
I think it would. Yeah.
I mean, our requirements for internal audits, which is, I mean, you can certainly do infection control internal audits, but our requirements indicate that they should be announced. There should be a scope. There should be discussions beforehand. They should be planned. You should, you know, almost, if you want to think about it, it's almost like a mini survey. You want to sit down with the team and say, my name's Jeremy. I'm going to be down here, you know, every first Tuesday. I'm going to be circling through your rooms. Here's what I'm just observing your processes and trying to help us identify any risk that may be present. And then, you know, on that day, going in and saying, hey, if you don't remember, I'm Jeremy. I'm going to be with you, watching you through this case. And I want you to just talk me through what you do, you know? And then at the end, don't, you know, again, it's not about calling somebody's mistakes. unless it's egregious. I mean, if you see somebody, truly break sterile field, you have a surgical content, you have to point that out. But if you see a process that maybe you're questioning or, maybe could be improved, that can happen afterwards. You can have that conversation and say, hey, I noticed that, you're doing X, Y, Z. Can you explain to me a little bit about, why we do it that way? And if you'll change the word from why you do it that way to why we do it that way, clearly changes the dynamic of the conversation, because now we're on a team and we're working together. And instead of why did you do it that way, which is accusatory, it's why do we do it that way? It's like, okay, help me understand. And then you can make your recommendations as an infection preventionist based off of those observations. But hopefully you're not doing it based off of one observation of one staff member or one surgical team one time. That's not really fair.
I like that. That's the exact right perspective. And if we're only up in the OR twice a year when something's going sideways, I mean, that's not very many bites at the apple to really make change, to improve culture, to really build that relationship. So as we round out part 2 of this conversation, what are some go and do's that IP can do, that the OR can do, get to a safer place with surgical site infections?
Well, I challenge anybody who's listening, who can introduce themselves to their counterpart first. So if you're the OR director or manager or even a staff member, who can get to the infection preventionist that works with the OR first? And if you're the infection preventionist listening out there, can you get to the OR director or frontline staff member before they get to you? Because that's where it starts. It starts in that collegial relationship. And, Rome wasn't built in a day. You're not going to change your culture in a day. Yeah, some of us, me included, some of us have to change our mentality and how we respond to outsiders a little bit and be receptive. And that's what I just challenge everybody to do is remember, guys, we're all on the same team. We all have the same goal.
I love it. That is excellent advice and very practical, tangible things that you can go and do. So, Lindsey, we want to thank you for co-hosting this episode and sharing your expertise, especially from our first case audience and frontline experts there. And Jeremy, we want to thank you as well for joining us and sharing your experience and really being able to show both sides of that coin, from the OR perspective, from the IP perspective. Exceptionally valuable. Thank you very much.
Of course. Thank you, guys.
Thank you.
What a fun 2-part episode with Jeremy to kick off this combined season. And really a great guest to have that, having both the OR background, having the IP background. And, you'll hear the concept of silo breaking come up throughout this season, but I thought this was a great kickoff. So if you didn't catch part 1, go back and listen to that. If you caught part 1 but not part 2, go ahead and listen to that. They're both phenomenal. I'm a little biased, and Lindsey, thank you for co-hosting on these episodes.
Yes, thanks for having me. We appreciated it. I can tell you that from an OR perspective, there was things I already knew. But from an OR perspective, there was a lot that I didn't know, and I have learned quite a bit. So hopefully some of our OR colleagues will learn quite a bit as well. I think my biggest takeaway is we got to have that good relationship with your infection preventionist. And honestly, that's probably something I'm going to take back to ROR and see what we can do. So great to collaborate with infection control and transmission. And on behalf of us at First Case, thanks for listening.
And for our transmission control audience, remember, infection stops where information starts. We'll see you all next week.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.